So good afternoon, everyone. I'll be presenting a pre-paper on to study the outcomes of topo-guided advanced surface ablation with accelerated UV cross-linking in keratoconus. No financial interest to disclose. So ours was a retrospective case study performed between March 2019 till December 2023 at a tertiary eye care center in Satara, Maharashtra, India. 55 eyes of 31 patients aged between 18 to 32 years were included in the study. The parameters compared were uncorrected visual acuity, best spectacle corrected distant visual acuity, keratometry values measured on pentacam, pre and post treatment astigmatism, pre and post treatment Scheimpflug topography maps, pre and post treatment aberrometry, particularly higher order aberrations. The patients included in the study were patients diagnosed with progressive keratoconus grade 1 and grade 2 on Amsler-Krumik classification. Patients' corneal topography demonstrated keratoconus on pentacam with progression in the past 12 months and which met one of the following criteria. The increase in Kmax by greater than 1 diopter, or increase in astigmatism by greater than 1 diopter, or best spectacle corrected distant visual acuity reduced by more than 1 line. The patients excluded in the study, excluded from the study were patients less than 18 years of age, thinnest pachymetry value of less than 465 microns, previous history of any refractive surgery, herpes keratitis, or any other ocular disease other than keratoconus affecting the best spectacle corrected distant visual acuity, the women in pregnancy or lactating period. The surgical procedure, mechanical debridement of corneal epithelium after marking with 9 mm epithelial refine was done, followed by a topo-guided advanced surface ablation using a wavelight IQ exam laser system. The maximum laser ablation depth was restricted to less than 50 microns with optical zone of 6 millimeters, and minimum pachymetry cutoff of 465 microns at thinnest point was used for all of our cases. The laser ablation was followed by accelerated cross-linking for 10 minutes at 9 milliwatt per centimeter square using intact axial cross-linking system and Peschke H riboflavin solution. After cross-linking, a short bandage contact lens in diluted preservative-free ketorolac was used and applied until full epithelialization, and it was removed after 72 hours. Now coming to results, there was statistically significant difference in uncorrected as well as best spectacle corrected distant visual acuity between pre-operative and post-operative comparisons. Best spectacle corrected distant visual acuity not only improved significantly from baseline to post-operative 1 month and 6 months follow-up, but also remained stable till post-operative 12 months follow-up. At post-operative 1 month follow-up, best corrected visual acuity improved by 1 lines in 35 eyes, 2 lines in 20 eyes, and at post-operative 6 months, best corrected visual acuity improved by 2 lines in 40 eyes and by 3 lines in 15 eyes. Best spectacle corrected distant visual acuity remained stable in all the eyes at 12-month follow-up. This is a chart showing the improvement in post-operative distant visual acuity. So Kmax decreased significantly at all post-operative visits compared to the pre-operative value. At 12-month visit, mean Kmax decreased to 53.13 plus minus 4.47 diopters as compared to the pre-operative mean of 57.23 plus minus 5.09 diopters. Although the overall difference in keratometric values, keratometric follow-ups were significant, only values at 6 and 12 months follow-ups were statistically significant as compared to 1 month values. So corneal higher order aberrations and coma decreased significantly at post-operatively 1 month and decreased continuously until 12-month follow-up. So as we limited our maximum corneal tissue ablation to 50 microns, it was not necessary to use mitomycin C after the combined procedure, and there was no persistent corneal haze in any of our cases. Our pachymetry cutoff was 465 microns, which ensured that residual corneal thickness remained greater than 400 microns in all of our cases. As the ultraviolet A exposure time required in accelerated cross-linking is shortened, it also improves the treatment efficiency and increases the patient's compliance. So there are a few case scenarios comparing the pre and post-operative visual acuity, this pre and post-operative topography at 3-month follow-up. So to conclude, our study not only showed significant improvement in best spectacle corrected distant visual acuity, keratometric values, and RMS of higher order aberrations and coma, but also showed good stability in refraction and corneal curvatures after simultaneous topo-guided ASA with accelerated cross-linking, especially when used in early keratoconus. Regularization of the corneal surface post-operatively improved spectacle subjective acceptance as well as the contact lens fitting in all the cases. Therefore, our combined treatment protocol is convenient, time-saving, and effective and safe. It should be strongly considered in cases with early keratoconus in which the thinnest pachymetry values are greater than 470 microns, and when the apex of the cone is within the central 6.5 millimeter optical zone. Thank you.
So very good results. And but why have you not used mitomycin C?
Ma'am, because we restricted the ablation to less than...
That is all right, but
yeah.
most of the studies which are published,
Yes.
they all advocate the use of mitomycin
Yes.
further. And how did you remove the epithelium with the
No, we have removed it mechanically, ma'am. For initial part of our study, which I haven't included in this, we had used alcohol, but what we observed in our practice scenario was in keratoconic is as such the epithelium is very loose.
Yes.
So it can come off very easily.
Yes.
So
Definitely, as long as you don't create any ridges.
Yes.
Thank you.
Yeah.